Good morning, good afternoon, good evening, whenever you're happening to watch this presentation. I will be talking today about the Integrative Model of Adjustment to Chronic Conditions. The short name is IMACC, and this is how I will be referring to the model in this presentation. But first, a bit about me. My name is Liz Hammond, and I was trained as a counselling psychologist in the UK. I have worked in brain injury rehabilitation and pain management. I have been a senior lecturer in counselling psychology, and I am currently chair of the International Network for Research into Psychosocial Adjustment to Long-Term Conditions. I no longer live in the UK. I've moved back to my home country, Denmark, where I'm the owner and a consultant at IMACC Rehabilitation Psychology. But mostly, really, I work as an independent researcher. I will be talking about psychosocial adjustment and rehabilitation from a generic point of view. So what is psychosocial adjustment? Why do we not call it biopsychosocial? What is involved in it? Why is it important? And how do we recognize when people have difficulties with adjustment? And finally, how do we help them? That will take me to talking about IMACC, which is an innovative theory about the process of adjusting to a life with long-term conditions. We will, of course, briefly touch on suitability considerations and how IMACC can apply it, a little bit about the current state of the supporting evidence and future research. There are a few abbreviations in this presentation. IMACC we have already discussed. In places I put LTC for long-term condition, and PWLTCs is people with long-term conditions. However, before we start talking about psychosocial adjustment, I think it's important to just consider for a moment, what is it like to live with a long-term condition? We know that there can be a wide range of impact, from minimal to completely life-altering, and obviously all of it depending on the condition. And there might also be aspects that cut across conditions to a greater or lesser extent. Things like stress, fatigue, pain, loss of spontaneity, limitation of choices, sometimes even reduced social contact and isolation. All of this leading to reduced occupational capacity, limitation of life trajectories, reduced financial circumstances. And also we have to bear in mind that having symptoms and using time for self-management requires motivation, energy and determination, all of which also takes time away from, if you will, normal life. That brings us to talking about what is psychosocial adjustment. So one suggestion is psychosocial adjustment is the psychosocial accommodation of a person to a life-altering event or transition. This doesn't tell us an awful lot about what is involved in psychosocial adjustment. So psychosocial adjustment is first and foremost a process of adaptation. So it's a process of change. So changes to lifestyle, health behavior, improvement, optimization of function, well-being, quality life, but certainly and to a great extent also adaptations in life roles and identity. It's important to look at also that the fact that there are different levels of adjustment. Poor adjustment is obviously when there's a lot of unhelpful behaviors and attitudes that are not helping the person live as well as possible. Good adjustment, what is that? I prefer to say optimal adjustment, So the best possible way of functioning and being and feeling within the constraints of the chronic condition. Few people reach the optimal, but the point is, how do we help people move closer to the optimal level of function and well-being? The process of psychosocial adjustment implies an awful lot of different types of challenges. People have to find their way through emotional and psychological reactions to the life change. The number of intensity of stressors is likely to increase. Are they able to find necessary motivation? Do they have the level of self-efficacy it takes to adjust and to cope with the condition? They need to learn self-management strategies, often through trial and error. And as I said before, adapting life roles, learning to use social support can be quite a challenge for quite a lot of people. Important for it is the perceived support and the perceived control. So not whether or not people have support or whether they are able to control the condition to a greater extent, but it's how they perceive it that's important. Personal values are important, meaning and purpose, and acceptance of changes to life and identity. Why do we not call it biopsychosocial adjustment? Well, of course, it's biopsychosocial, but the thing is, the biomedical and biomechanical approaches are highly systematic and specialized, and we need to bring our psychosocial understanding and approaches up to the same level as the medical and biomechanical approaches. This is necessary in order to allow all rehabilitation professionals to truly work in a biopsychosocial manner. Why do we need to put effort and resources into helping people adjust psychosocially? Well, we need to do that because a lot of bad things can happen if people with long-term conditions do not adjust. Just a few examples: poor quality of life, poor symptom control, poor mental health, typically a worsening of the condition, or maybe long-term complications like in diabetes, for example. Often relationships problems comes when there's no good control and no good adjustment. There might be loss of occupation, loss of life roles, and negative identity changes. So how big a problem is this? Well, for the moment, putting aside the current COVID-19 problem, the past decades have seen a continuous rise in the burden of chronic disease and disability. One study looked at Scottish general practices, where they found over 42% had one or more long-term conditions. Over half of those had multimorbidity, so 2 or more long-term conditions. Of those with long-term conditions, almost 20% had physical and mental health comorbidities. Multimorbidity is increasing with age and is more common in deprived population. The societal problem we have with this is that it is very costly. For instance, around 25% of the UK population live with a chronic condition, and they take up 70% of the National Health Service budget. What studies have found is that the better you are at managing your health condition, the less you use the health services. And this study looked at how highly activated people were in terms of managing their condition, and only 13% managed their condition optimally. 22% were at level 1, so did not actively contribute to their health care. So certainly over 40% do not manage their condition very well. Generally, we use the figure of 50% because other studies say this, but around 50% do not manage their condition well, and therefore have poor quality of life and using health services much more than they otherwise might do if they were helped to manage better. So how do we identify adjustment difficulties? Well, psychiatrically, there exists criteria for what's called adjustment disorder, which is having emotional and or behavioral symptoms within 3 months of a specific stressor, in this case a long-term condition, occurring in life. Crucially, it's experiencing more stress than would normally be expected in response to this event. However they measure what would be normally expected, I do not know, but I'm sure you have all experienced this thing of puzzling how is it that this person is finding this so incredibly difficult. Importantly, we're also talking about those mental symptoms not being a result of other mental disorders, mental health disorders, or part of normal grieving. However, many people have difficulties with their psychosocial adjustment without necessarily having a full-blown adjustment disorder. My personal rule of thumb is that you can recognize it if the condition and the role of the condition in the person's life goes out of proportion. So, for instance, I'm sure you've heard it before, I can't do this and that because of my condition. Sometimes that is realistic, relevant, correct. Sometimes it's maybe a perception. You sometimes get people who say, I refuse to let the condition take over my life, so they will not do the self-management regimen because, no, it's taking over my life. Or they might have anxiety and low mood and blaming the condition for that. So what helps? Well, obviously self-management, acknowledgement, expression of emotions, reflections, supportive relationships, etc., etc. But we cannot expect everybody to have access and the ability to benefit from all these different aspects. And indeed, it is shown that psychosocial rehabilitation in general is not addressed adequately for people with long-term conditions. Psychosocial rehabilitation is actually a known concept within psychiatric settings. Often for people with severe mental health problems, trying to rehabilitate them back into the community. Lots of psychological therapies are useful for psychosocial adjustment problems, like cognitive behavioral therapy. Acceptance and commitment therapy is quite widely used in pain management nowadays. Compassion-focused therapy, I think, is excellent in rehabilitation, and mindfulness and reflection is really, really important. However, none of these are specifically developed for psychosocial adjustment to long-term conditions. In my opinion, psychosocial rehabilitation for long-term conditions needs to focus on the primary problems. Primary problems being unpleasant symptoms, functional issues, and as a consequence, limited capacity for participation. This obviously can lead to issues with making daily life and relationships work, including going to work. It can be difficult tolerating a life in poor health. In some cases, it can lead to social isolation, and for many people, it can lead to mental health problems and identity changes that might be negative. Again, in my opinion, I think it's important to focus on the primary problems first and the mental health problems second. Obviously, if you count mental health conditions as long-term conditions as well, we have a slightly different picture, but still it's about symptoms and function, no matter what the condition is. I have already mentioned the ICF a couple of times, and it is of course the WHO's model of how health conditions impact on a person's body function, their activities and their participation in life. The model acknowledges that there are environmental and personal factors that impact also in addition to the health condition. However, what the ICF does not explain is how these different areas impact on each other dynamically. What is actually happening? What is the process? And they do not explain the process of change, the process of moving from relatively poor adjustment to relatively good or optimal adjustment to any given long-term condition. This is what the IMACC can provide, and we have actually done a study mapping the IMACC onto the ICF, and the two models do seem compatible. Which takes us now finally to a presentation of the IMACC. So, as mentioned, the psychosocial adjustment is a process. An IMACC is a process model, kind of seeing adjustment from the inside. It is what is happening as a process in the person. We believe that it is the first clinically applicable process model of adjustment. In many ways, what I am going to tell you will be very familiar, because it is not a revolution in saying everything we knew was wrong. Of course not. Really what IMACC is kind of a repackaging of rehabilitation knowledge. It is tying everything together and showing the process of psychosocial adjustment and all the things that are relevant in that process. So here it is, the IMACC model. A lot of health professionals scare a bit when they first see it, but there's no need. People with long-term conditions, however, they absolutely love it. They can see themselves in the model. The IMACC model consists of 3 levels, or 3 submodels, if you will, that interact with each other, and each of those models are relatively simple. So the first level is the precondition, function and personality. The second model is the ongoing adjustment cycle, which is the continuous process of adjustment post-onset of the chronic condition. Finally, the third level is the maintenance cycle. I am aware that my little video is obscuring part of that model, but you will get more detail in a minute. One of the main strengths of this model is that it allows you to systematically identify barriers to adjustment. And in this presentation, you will see different fonts because I've tried to include a few examples of theory and a few references, but also examples of intervention options. So if we identify a problem, we can also identify an intervention, one of the usual interventions that we already know very well, that might address this problem. And in some cases, I have also included some examples in the form of a fictitious case story about Kim. I'd like to start by introducing you to Kim. She's 45 years old, married to Simon, has a long history of persistent low back pain, which has gradually deteriorated over a number of years. She's trying to get back to work after long-term sick leave, but really struggling. She has elderly parents and grown children that have almost left home. The first level of the IMACC model is the preconditioned personality. It has two model components. We will start looking at the component schema and rules. This is the personality prior to the need for adjustment. So it's really everything about the person. It's their identity, character, temperament, experiences, motives, and any other aspects that influences the person's habitual thinking, emotionality, and behavior, including health behavior. Obviously, what we are most interested in are those aspects that are impacted by or are impacting upon the long-term condition. Schemas and rules are not terms that are very helpful when you have a therapeutic conversation. So when talking to people with long-term conditions about this topic, it's helpful to refer to it as beliefs, attitudes, and habits. In the research, I found 4 different subcomponents of this, and we will look at each one of them in turn. The first and maybe most obvious subcomponent is health beliefs. This area relates to theories such as self-efficacy and locus of control. And if we take the example of Kim, she has external locus of control, which means, yeah, the doctors need to fix this. She has no time for self-care, and she's basically taking her body for granted. So what might you do about those kind of things? Well, obviously, education is quite important, motivational interviewing, and maybe some cognitive behavioral therapy to help Kim understand where these beliefs come from and how they are maybe less helpful in her current situation. The second subcomponent is self-beliefs. So things like self-esteem, identity, meaning and values. For Kim, she has quite low self-esteem. Her thoughts about herself is, I'm nobody. But helping others actually gives her value, she believes. The third component is called procedural. It would be what most of us call habits. So it is what we do, it's our behavior, and it is typically in line with what we believe. Theories that are relevant for this component is conditioning and habit formation. Looking at Kim and her habits, for her hard work is just the norm. Exercise is pretty much an alien activity, and she's really too wired to rest. Her stress levels do not allow her to relax and rest. The fourth and final component is interpersonal beliefs. Research so far seems to indicate that this may be of really great importance to adjustment. So I will be talking a little bit about attachment. There are many things that contribute to our interpersonal behaviors and interpersonal beliefs, but attachment is quite fundamental. Attachment is the bonding and the relationship we have with others, especially really close relatives, and it's both the actual and the perceived relationships. If you look at Kim's relationships, she is very independent, mostly because she is not trusting of others. So that has the expression of having to do everything herself. She must do things for others as well. She cannot accept help, and she is not good at asking for help either. We will look a lot more into this in a minute. Just briefly about attachment. It's a theory that is relevant both to psychology and to evolutionary theory. It is claimed to be a primary biological function. So if a baby has attachment, it will have protection, access to food, learn about the environment, etc., etc. So it is fundamentally important for us all. As it is fundamentally important, both psychologically and biologically, it also is a primary driver of behavior. Attachment is not just one thing. There are different so-called styles of attachment. A simple way of expressing that is how much a person trusts in themselves and how much they trust in others. So the attachment style has an influence on how relationships are perceived, including the relationships we have with health professionals. The red writing on the graph is an approximation of how you might, as a health professional, experience those attachment styles, whether people are quite dependent or they take responsibility for themselves whilst listening to you, whether they're very independent and rather want to do things on their own, or if they're quite inconsistent, which is one of the more rare attachment styles. So the main point of this is that a person's perception of relationships influences their health behavior, well, their behavior in general. So the attachment is kind of a priority. This is why the therapeutic relationship is very important when you work with clients or patients, and it is also very, very important if we want to influence health behavior change. So why is this important? Before we get to why IMACC says it's important, I just want to show you that theory in general, lots of theories in general point to this importance. So attachment is important for emotional regulation, coping mechanisms. It has an influence on illness behaviors, on symptom reporting, on healthcare utilization, restriction of normal activities, and individual differences in emotional and behavioral responses to stress. So that was the person, or the personality, if you will, in the first level of IMACC. The second component is critical incidents. So this is what happens to the person and how they experience and perceive what happens to them. So that is basically the onset of the long-term condition. So it might be sudden or gradual. So it might be an unexpected diagnosis. It might be an accident that happens. It might be surgery that goes wrong. Or in our case example, Kim, it might be developing over time. For instance, the low back pain, starting intermittently and then becoming chronic. Typically, when people get ill or disabled, there is a period of repair focus. So they work on the cure, on the recovery. People have various time points for realization. Obviously, if you have lost a limb, for instance, you do know that this is not going to be reversed to normal. But low back pain is a typical one where the realization that things are never going to be the same again happens very far down the line. And sometimes it's social issues that triggers this realization. For instance, losing one's job after several periods of long-term illness. Other things that might be a critical incident is iatrogenic issues. For instance, as I said before, the surgery that didn't work, or the doctor that said something the wrong way, or whatever. So when should the adjustment process start? When does the adjustment process start or fail to start? Well, it's not necessarily from the outset of the long-term problems. If they're not too bad, people might get away with their habitual behavior for quite a while. Again, typical for the low back pain. But really, it needs to start when changes are required to maintain function and the equilibrium and positive quality of life. That doesn't always happen, which then that's where you see a decline. Sometimes it has to go to the point where coping becomes really maladaptive or stress becomes really dominant before someone picks up there's an adjustment problem here, we need to look at the adjustment. Unfortunately, very often it is not even picked up by then. But this is what we need to get better at. The second level of IMACC is the ongoing adjustment cycle. It consists of 5 areas where the person will meet some challenges that need to be negotiated over time. These challenges might be overcome and facilitated by things like, for instance, good levels of self-efficacy, good levels of support, etc. But the adjustment process might also stall if the person run into barriers in one or more areas, and barriers that the person finds difficult to overcome. The first area of adjustment is called taking stock. The definition of this area is This is the area where you see the emotional reaction to what has happened and to the message that this is likely to be long-term. It's the what now, what does this mean for me reaction, what's going to happen now, and this includes evaluation of lifestyle, for instance. But crucially, it also involves the motivation to change, and sometimes this can be a barrier to further adjustment. If we look at Kim's case story, for her, the taking stock, the big barrier for her is denial, which could be interpreted as lack of motivation to change. But if we look at it a bit more closely, the barrier that Kim is up against is that she feels too scared to even contemplate changing her life. She's afraid of not being able to work, afraid of not being able to look after her elderly parents, not being able to keep her house in order, not to be able to help her children. But for most people, they get to a point, there's no way back, I have to do something about it, and this is where Kim is now. The second area of adjustment is called learning new, and there are different aspects to that. First of all, people need to learn what does this mean, this condition, factually, what are the options, what are the management strategies, and it's important here also to sort of address any beliefs or misconceptions against relevant information, because people act and behave according to what they believe about their illness. Obviously, in most cases, really, it's also important that they have the skill, that they learn the skill to manage their condition. In diabetes, for instance, doing injections, in pain management. I'm sure you know very well what kind of management skills are required there, and things like, for instance, pacing can be really, really difficult to learn. Interestingly, what turned up in the research as quite significant was the need to learn new attitudes. I'm sure you know a lot about attitudes to exercise, for instance, but actually often it's attitudes to daily living which might need to be changed and might not be discussed in the clinic room. So old attitudes that are now less functional, they need to be replaced with new attitudes that are more functional. Again, if we look at Kim, she understands the need that her behavior needs to change, the way she moves and the way she looks after herself, but there are some major snags for her. In terms of health beliefs and health habits, so the procedural schemas, her thoughts are, it takes too long to do things in a different way, I'm too tired to do exercise after work, I don't have time for self-care. I'm sure you've heard it all before. Interpersonally, her attitudes and her perception of support from others means that she doesn't like to ask others for help, and her attitude to herself, which really links closely to her values, is that you must complete the job before taking a break. All of these attitudes make it difficult for Kim to change her behavior. The third area of adjustment is support. And you could say that the whole of the IMACC model is intrapersonal. It's what goes on in the person. But in this particular area, this is where the person meets the world around them. Very much people around them, but also the environment. So socially, that could be family, health professionals, the wider social context, work, etc., etc. But it's the perceived social support which is really crucial for how a person reacts to other people and make use of the support that may be available. Environmentally, it's sometimes a little bit simpler. So there might be environmental barriers at home or in the local community, access problems, etc. Again, for Kim, she's sort of got to the point that she understands that she needs to let other people help. But here we have her interpersonal snack. She doesn't really trust people that they will do things the right way, so, i.e. the way she wants it to be done. And generally she has a low sense of perceived support because she thinks that other people don't have time to help her and she doesn't want to be a burden. Furthermore, she has this attitude that she has to take care of her family by doing everything or as much as possible for them. This is who she is. And her environment is not particularly good either. It's an old house, it's not functional. And also within the family, they're used to letting her do the things her own way because it kind of works better that way. The fourth area of adjustment, letting go, is probably the one we're most familiar with. It's this thought that people have to process the losses, the functional losses they've experienced. They need to let go of the past function, but also they need to let go of those old attitudes that keep getting in the way. The fifth and last area of adjustment is called acceptance and integration, and this is where new attitudes and habits are embedded through repetition. This is also where you see the growth of acceptance, and if the person manages to achieve positive changes in attitudes and habits, you can see that can then feed back into the personality and affect relevant positive identity changes that will help the person sort of reorient themselves in their new life. Before we move on to the third part of IMACC, I just wanted to give you a super short crash course in cognitive behavioral therapy because that's relevant for the third part of the model. You might already know this, but the point is that people can get into situations where automatic thinking, automatic behavior is triggered because they are challenged by the situation, and there is an interaction between their thoughts, their feelings, the physical sensations they experience, and the behavior that ensues of that. And often that becomes a vicious cycle that people cannot break. The third part of the IMACC model kind of follows this idea of a vicious cycle, but with a little twist. So we have the trigger, and that can be challenging situations or challenging aspects of the condition. For instance, in epilepsy, the fact that it might be unpredictable. So what happens is that you have the thoughts, they form a cognitive conflict. So there's a conflict between the adjustment areas, typically between learning new, letting go, and support. This conflict then triggers the cycle, and the conflict needs to be resolved in order to move on. Let's see how that looks in the following slides. If we look at Kim's maintenance cycle, we know already about Kim that she is not very good at using her support because she has a low perceived sense of support. On the other hand, she can't say no to helping others because that's part of her values. So doing for others is important. So whenever she comes in a situation where she either should ask for help or really should say no to what others people ask of her, she has a conflict between letting go. So she can't let go of the fact that she used to be able to do X, Y, and Z quite easily, but can't do that anymore. Learning new, she's not learning the new behavior and the new attitudes. On the contrary, because she hasn't really changed, she's learned something negative about herself. She's learned, she thinks that she's a burden. She certainly confirmed her own belief that asking for help shows weakness, and she tells herself she doesn't have time for pacing. But what really makes this dilemma into a strong conflict is others, so people around her, particularly her family, because there is the notion, if I say no, or if I ask them to help me, I will be letting them down. It makes me a bad mother, a bad wife. I've got to look after them. So this is where the strong conflict comes, and this is what we talked about before, about attachment being the primary drive. This is what is most important for her. So emotions that comes out of that, when she's really upset about this, you can have anxiety, stress, guilt, shame, all kinds of emotions. These then create distress, arousal in the body, but also because she tenses up, etc., etc., increased pain, which just makes the whole problem worse. So her actions are then either activity cycling, so she's pushing through the pain and does the job that needs to be done, or do things for others, or she finds excuses and feels really bad and really guilty about it, or she's apologizing profusely, again feeling bad about it. There's fear avoidance of certain movements, postures, all of it making things worse. So how do we help Kim move on with this? How do we help her solve this inner conflict that creates a vicious cycle for her? Well, one thing you could do is map a number of interventions to this model. If there are tools you already have or have access to colleagues who have, such as letting go, that could be helped with some supportive counseling, about sensations in the body, relaxation, mindfulness can help there. Behavioral experiments, which is also a cognitive behavioral term, so trying to do something in a different way, so getting a new experience with trying things differently. But really, if you share this maintenance cycle formulation, as it's called, if you share that with Kim, she might become aware of these patterns that she's in, and together maybe you can find a way forward and help her try, or maybe go and talk to the family, talk about expectations, maybe her perceptions of them, check them out. Are they really a reality, or is the family in fact worried and wanting to help, but she's not letting them? So using the IMACC formulation can actually in itself move people forward. So to summarize how the IMACC model works as a whole, you have up here, you have the preconditioned personality and the critical incidents which lead to the need for adjustment. And these both of these aspects, they then feed into the ongoing adjustment cycle, where elements from the pre-personality factors or the critical incidents may form barriers in one or more of the adjustment areas. They might also be facilitative. So, for instance, a good level of self-efficacy and self-confidence might be a facilitating aspect of the personality. So it's always important to look at both strengths and unhelpful attitudes and behaviors. So any barriers or snags that may be present in the ongoing adjustment cycle, they then form triggers for the maintenance cycle, creating this cognitive conflict that requires a resolution. If a resolution is found, which is typically a change of attitude or behavior, then that feeds into the area of acceptance and integration. However, if a resolution is not achieved, so we have the maintenance, then it's a matter of barriers creating the conflict, not getting resolved, getting back into the ongoing adjustment cycle, and then carrying on again and again over time. And this is typically where people are trying to keep maintaining their old attitudes and their old habits. If, however, a resolution has been achieved and there's a higher levels of acceptance and integration and a change of habits and attitudes, that will eventually feed into the personality and create the identity change that is required for a person to accept and live well with their long-term condition, and also managing this condition well. However, if there's a lack of a solution, you can see the same process happening, except this time in a negative way. So you have a negative development of the identity, and with that you will get a decline in the person's function and mental health. So IMACC as a whole is a model that describes the dynamic process people go through as they change, whether they change positively by changing relevant attitudes and behaviors, or whether they change negatively by trying to maintain function and life as it was, although this is no longer possible. So this gives us this understanding, and it can work really well if you sort of show the people you're working with how this process works, because it allows them to see the patterns for themselves, and it allows them to reflect on further changes they might have to make. However, this is maybe not suitable for everybody, so it's about finding the right level for the person you're working with. Generally, I would say that IMACC is very suitable when adjustment difficulties are the main presenting issue. It is a lot more challenging to use IMACC when there are significant trauma background which has not been or cannot be addressed. Should that be the case, it might be essential to work alongside trauma treatment by a psychologist or whatever is relevant. And another challenge is if there are other types of significant mental health problems, long-term mental health problems that are not due to adjustment difficulties, that would also present the challenge in terms of using IMACC. That would require, if you will, further multidisciplinary involvement. This slide shows some of the ideas I have on how IMACC can be used. But I will say at this point in time, there is limited evidence base because we're simply not that far in the development. But definitely, I think IMACC can be used as an integrative framework, which can encompass existing theories, interventions. It can be used for interdisciplinary work. It can be clinically applied to individuals or in groups. It can be a framework for service development. It can be used for training purposes. And certainly can and is for the moment used as a framework for research. It can be used to identify gaps in current knowledge and to develop projects within the IMACC framework. The current state of evidence is mainly theoretical. So we have the original study, a study mapping some secondary data onto IMACC concerning adult onset epilepsy. We have mapped the IMACC onto the ICF model, and the two models seem compatible. We've done an impact case study implementing the IMACC model in various mental health and physical health services in the northeast of England. And currently I'm working towards clinical testing, and there are some ideas around of using IMACC as a shared model for interdisciplinary teams. Finally, I'd like to draw your attention to our international network of research into psychosocial adjustment to long-term conditions. It's a very new network, certainly still in the growth phase. We have a leadership board with researchers and clinicians from the UK, Denmark and Australia, and hoping to expand that further. Our mission is to raise awareness and increase theoretical and applied knowledge and understanding of psychosocial adjustment to long-term conditions. You can join the membership. For the moment it's only on LinkedIn, but we are working on a website, and it would be great to have all kinds of rehabilitation professionals joining us. So this is me. You're welcome to send any questions you might have to my email address. And don't worry, you won't be signing up for any newsletters or anything. So if there's something which you need to have clarified about this about this talk, please feel free to contact me and I'll reply as well as I can. Many thanks for your interest. I hope you found it useful, and I wish you a pleasant day.